Okay, so this is going to be on inherited ovarian cancer. And I put breast cancer in parentheses because it's really hard to separate the two. So I know we did this already in life cycles, but like I said, it's really hard to kind of separate the two of them. So fortunately, ovarian cancer is less common than breast cancer. About 1% of women will develop ovarian cancer at some point in their life, but it's more likely to have an inherited cause. So 20 to 25% have an inherited cause, whereas it's a smaller number in breast cancer, isolated breast cancer. So it's actually, in most cases, the same genes, the BRCA1, the breast cancer gene 1 and 2, and this is a review from the breast cancer case in life cycles. These genes work in the G2 stage of the cell cycle, and these genes are involved in preventing cells to undergo division if there's too much damage. When an individual is born with one non-functional copy of this gene, in the Knudsen two-head hypothesis, the second hit is also needed before you develop that cancer. So one copy of this gene that's functioning is enough. 89% of women born with a non-functional copy of the BRCA1 or 2 gene will develop breast cancer by the age of 70. With regards to ovarian cancer, if the BRCA1 is abnormal, the risk for ovarian cancer is about 40 to 60% in their lifetime. And if it's a BRCA2 mutation, it's about 20 to 35. Yes, that's lower, but they're both bad. There are 3 common mutations, 2 BRCA1 and 1 BRCA2, that are more common in the Ashkenazi Jewish population. And again, this probably has to do with founder effect. So here again, we have a pedigree, and what we'll see is a pattern. We see breast cancer at young ages. We also see ovarian cancer, and men, while they don't have breast or ovaries, they do have a prostate. So they are at increased risk of prostate cancer, and often at a younger age. So this would be a family history consistent with a BRCA1 or BRCA2 mutation. Even if this woman, for instance, died of breast cancer, let's say 80, this is still the concerning side because we have breast cancer 54, breast cancer 35, breast cancer 45. So again, the BRCA1 and 2 are tumor suppressor genes, and they're inherited in autosomal dominant fashion, but you need to lose the second copy before you have the problem. And this is also a slide that I showed you in the breast cancer case. So females with breast cancer, again, 89% versus 12 to 13% in the general population. A second breast cancer, 64% versus 11%. Male breast cancer, 6 to 8%. Ovarian cancer, about 44%, 1.5% in the general population. So even though it's less likely than this, it's still pretty high. And then we also have pancreatic cancer that can occur in the BRCA1 or 2 mutations. And again, these breast cancer, male breast cancer, and we don't have prostate up here, can affect males. So why have genetic testing? And I've done genetic counseling for a long time, and people used to say, well, why would I want to know this? Like, to give myself guilt that I hand this off to my family? Like, how is this going to help me? I don't need to deal with this guilt. I don't really see any reason to do this. And that was actually the answer that I got for a long time until about 5 to 10 years ago. We started having different managements by understanding what these genes do. And you learn a lot about that in pharmacogenetics, pharmacology, of what does this gene do and how can we treat the cancer better. So the answer is management. So a lot of times we actually see these women urgently because they're surgical decisions. For instance, if they had a lump and the decision is, do you want to do a lumpectomy or do you want to do a bilateral mastectomy? If there was a family history of breast cancer, even though it was a small in situ tumor, you might go with the bilateral mastectomy versus a lumpectomy, because a lumpectomy would require radiation. And if you had one of these genes, it could make it a lot worse. So the surgical decision of the cancer oncologists is actually really important nowadays by these genes. So the next slide I want to show you, if I can get my mouse to this stage, is management. So again, if a woman is positive for the BRCA1 or 2, there's also things she can do if she knows before she has cancer to decrease her risk of cancer. And one is stay on oral contraception. That can lower the risk of ovarian cancer. So this is ovarian cancer by 50% just being on birth control. Tamoxifen can decrease the risk of breast cancer by 49%. Mastectomy decreases the risk of breast cancer by 90%. But this is actually an interesting one. If you get your ovaries out, this is an ovarian cancer case. If you get your ovaries out, you decrease your risk of ovarian cancer by more than 90%. It's not 100% because there might still be tissue. And there actually are some people that believe that it's actually the tubes and not the ovaries that start breast cancer. So you need to not just take out the ovaries, you need to take out the tubes too. But taking out the ovaries and the tubes can decrease not just the risk of ovarian cancer, but also decreases the risk of breast cancer by 68%. And people believe that has a lot to do with hormones and things like that. So if a woman walked in at 35 and said, my mom had breast cancer, she was BRCA positive, the risk that this woman is BRCA positive is 50%. If she ends up being that unfortunate 50%, there are things that could be counseled to her to decrease her risk, to improve her chances of survival of getting this cancer. It's not a death sentence. It's something that we can do to manage. And testing changed a lot, and I know I talked about this in the breast case, is the Angelina effect. Offering women risk-reducing mastectomies doesn't take 100%, but it significantly decreases it. If no surgery, very close breast surveillance starting at 25, often with MRIs and things like that, recommending risk-reducing bilateral salpingo-oophorectomy. Again, taking the tubes and the ovaries out. If you're 35, did you complete your family? Are you planning on having another baby? Because having the babies is like being on oral contraception. Your ovaries aren't busy making new eggs, so that's probably a safe time for you. So have your kids, be done, and get everything out so that you can raise your kids. So the genetics of this have really, people's acceptance of doing this testing increased significantly once Angelina came out and explained, because her mother was a carrier of a BRCA2 gene, and she had her children, and she, had a surgical procedure. So additional single genes associated with breast cancer, again, we talked about Li-Fraumeni, but this is the scariest of the tumor genes, again, because it affects many areas of the cell cycle, the S1 and the S2, the G1 and the G2, and it results from a mutation of the TP53, which is located on chromosome 17, and we also learned, deletions on 17, deletions, mutations. The loss of the TP53 gene is it's something that slows down cancer, so cancer cells like to get rid of it however they can. They either delete it, they mutate it, or something. But if you're born with one copy against you, you're in trouble. So it makes surveillance difficult. So these are the kinds of cancers that occur with Li-Fraumeni. And again, this is not, we find a mutation of the P53, because if we look at tumors, and nowadays we look at tumors all the time, we do the genetics of tumors. There's something called Tempus. They actually do the genome of these tumor cells. There's a difference, and I've said this 100 times, but I'll say it 1,000. There's a difference between what you're born with. So I'm talking about germline mutations and what the tumor's mutations are. But if you're born with this in every single cell in your body, every skin cell, every brain cell, every heart cell, every ovarian cell, you're kind of in trouble. So breast cancer, if you have a germline P53 mutation, 80%, brain 22%, and again, brain tumors usually not genetic, sarcoma 20%, colorectal cancer 14%, pancreatic 11%, which is similar to the BRCA1 and 2, adrenal cortical carcinoma, 10%, bone cancer, 9%, leukemia. Again, leukemia is usually not an inherited cancer, 8%. And so when we look at this family history here, and we see all these weird things. So this person is 40 and had breast cancer at 30. Her father had osteosarcoma at 25. He had a sister who had leukemia at 10 and died at 12, a brother who's fine, and another brother that had colorectal cancer at 45. And their mother got breast cancer at 39 and died at 40. Now, if you look at this side of the family, here's somebody that was 65 and died because he was a smoker all of his life. Again, people, if you don't die of heart disease, you die of cancer. People die of cancer. When somebody, has breast cancer at 80, or, they're a smoker and they get lung cancer, we have an environmental reason why this happened. So this is really coming from this side of the family. And talking to medical students about STEP, a pedigree like this has been seen on STEP a couple years ago, so it is something you need to know. Peutz-Jeghers is a mutation of a different gene, the STK11. It's dominant. There's an increased risk of ovarian cancer and breast cancer, and there's freckling of the lips. So breast cancer, 32 to 45%, colon cancer, about 39%, and these are these hematomas. Stomach cancer, 29%, and ovarian cancer, 21%. So understanding family history patterns. Many of the inherited disorders we have discussed overlap. The BRCA1 and 2, the breast cancer is the most common, but you can see ovarian, prostate, pancreatic. The P10 is another gene that I didn't talk about. It can have breast, endometrial, colon, Peutz-Jeghers, STK11, breast, ovarian, colon, stomach, and then the P53, again, the strongest tumor suppressor affecting both stages of the cell cycle, very early, all kinds of cancers that seemingly, again, sarcomas, leukemias, brain tumors, things like that, is a germline mutation of P53. So, in a family history, an individual's mother had breast cancer at 44. She is alive at 59. So this is this woman. Her sister had breast cancer at 48, and she died at 50. The patient's paternal grandfather died at 64 of pancreatic cancer. This says prostate cancer. Sorry. We're concerned about the maternal history, likely BRCA1 and 2 cancers, and prostate. Change this. And they're of Ashkenazi Jewish descent on this side of the family. Who is the best person to test in this family? She's worried. She's 30. Her mom had breast cancer. Her aunt had breast cancer. Her grandpa had prostate cancer. She's worried. But who is the best person to test? And the best person to test is actually not her. Because if she's negative, is she negative because she didn't inherit the gene? Whichever gene this is. Or is she negative because that's, it's something different in the family? So because mom is alive and she had breast cancer, she's actually the best person to test. And the reason I show you this is we do this all the time. Somebody comes in, our patient is sometimes not the person we test. We look at this family history and choose the best person to test. So a woman's diagnosed with breast cancer at 22. The family history indicates the mother died from breast cancer at 30. Her brother was diagnosed with osteosarcoma at 15. And the uncle died of neuroblastoma. The best thing to be tested for is TP53. Again, and if you don't know all the rest of these genes, again, this was the Peutz-Jeghers. This is a gastric cancer. I took this from one of those board books. Here's the P10 that they made me stop talking about Cowden syndrome. But if you don't even know, just, pick the right, the thing that seems like it makes the most sense. So that concludes this lecture.